Wait for a while.
Hello.
Okay, you are able to see.
Hello.
Able to hear. Okay.
Hello.
Just keep in touch.
Yes,
Hello.
we can
will
hear
try
you.
to do
We
it.
Are
can
you
hear you.
audible?
Yes, you are audible.
So
Hello.
this is audible. All right. All
Yes,
right.
you are audible. Kindly go
Hello.
ahead.
We should be starting in next 2-3 minutes. Okay. Yeah. Good. Thank you.
Hello. 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 Are we audible?
Yes, ma'am. Yes, you are audible. Kindly go ahead. Please start your presentation.
Nine.
Okay. Thank you. Thank you. Most welcome.
3 years old male child, first by birth order, born out of non-consanguineous marriage, resident of Bhiwandi, informant mother, presented with complaints of abdominal distension since 2 months and fever since 2 weeks. Child was all right 2 months back when mother noticed abdominal distension more in the upper abdomen, which was progressively increased over past 2 months, associated with pain, which increased in intensity, not associated with pedal edema or periorbital edema. In this span of 2 months, child had decreased appetite, decreased playfulness, and decreased activity. Fever was undocumented, no diurnal variation, not associated with any chills, rash, results on symptomatic medication. There is no history of any previous umbilical catheterization, history suggestive of any umbilical sepsis in neonatal period, no history of blood transfusion, no history of any petechiae purpura, no history of any delayed milestone seizures or failure to thrive, no history of any jaundice in the past, hematemesis melena, hematochezia, or dilated veins on the abdominal wall, no history of any altered sensorium, unconsciousness, coma, or any seizures, no history of any COX or COX contact, no history of any decreased urine output. Past history.
Can't hear very well. Maybe not loudly.
We can hear the fan. Admission at first admission at 1 year for febrile seizure, second admission at 2.5 years for enteric fever for 5 days. Antenatal history not significant. Birth history full term normal vaginal delivery, cried immediately after birth, birth weight of 2.5 kilo, no NICU stay. Immunization till date. Developmental history age appropriate. Diet wise consumes all food groups. Required is 1400 kilocalorie, intake is 1100, total deficit of 300, protein deficit of 5 gram per day. Family history is not significant. So
The first line.
So who wants to analyze? Not you. Anybody? Hello, am I audible?
Yes, Dr. Khare.
Hello, can you hear me?
Yes, Dr. Khare, we can hear you.
Hello, can you hear me? Anjali,
Yes, we can hear you.
can you hear me, Anjali?
Yeah.
Yes, thank you. So, wants to analyze 2 months. Yes, 3-year-old child with abdominal distension for 2 months. Want to try? Yes.
3 years old nature presented
You know the patient, correct?
Yes.
You want to try?
2-year-old patient with abdominal distension since 2 months and fever since 2 weeks.
First, take
Yeah.
only one symptom. Which is the first symptom?
Abdominal
So
distension.
analyze abdominal pain first.
The 5 reasons of abdominal distension are fluid, fetus, feces, uh, uh,
Not fetus.
but,
Flatus.
fetus.
That F may not be applicable here, but
Hello, hello.
do you want to give the characteristics of these? You said this abdominal gaseous discharge, then fluid. So let us first analyze the fluid and see whether it fits in. What are the characteristics of flatus?
Latest will be more generalized and fluid initially will be in lower uh, uh,
Anything more about the flatus? Will it be constant or it will be changing? It will be varying, especially after the child passes gas. So it is there, sometimes it is not, so the intensity of the fluid, the discharge will vary. It will be generalized because the flatus will be there all over. What about fluid? That will be good. Yes. Type of distension. Penetrate. Nasal position. Usually uniform distension. It may not be dependent every time unless the child is standing. Most of the time it's uniform. Will it be bulging the flanks? If it is significant, then it will be often bulging the flanks, otherwise it will be uniform distension. Any other? Upper abdominal distension, what else is there in the abdomen above the umbilicus? Organomegaly. So can it be will the organomegaly occur over 2 months gradually? Yes, it can. And it will not have the waxing waning, it will be constant and slowly growing. Upper abdominal. So what are the possibilities? Can it be kidney? Can it be intestine? Hepatomegaly. Usually a hepatomegaly gradually increasing over a period of 2 months. Can it be splenomegaly? Can it be pancreatic? Pancreatic pain coming over 2 months and significant is uncommon, doesn't swell up as much. Splenomegaly will be presenting as more as a lump inside, and renal masses will not occur the way gradual distension up. So this particular child has probably gradually increasing abdominal distension over 2 months in the upper abdomen because of hepatomegaly, and probably not as a result of fluid or this some fluid there, at least it is not obvious. Okay, so what are the causes of hepatomegaly over period of 2 months, gradually increasing in a 3-year-old child? So far, we don't know the past.
Look at the details, so.
Apparently, all right, 2 months back, abdominal discharge more in upper abdomen, progressively increasing over 2 months. Associated with pain, which increase in intensity, not associated with pedal edema, periodic edema. In this span of 2 months, child had decreased appetite, decreased playfulness, and decreased activity. So some constitutional symptoms. Now, so what is added here is abdominal distension, painful abdominal distension. What can be the cause of pain? Anybody? Do you think if the pain has occurred over a period of 2 months, that size itself may give rise to some pain or discomfort, more than a pain, often a discomfort, because the pain has occurred relatively over a short time? Can there be significant pain? Pain is also important. Can there be any pain? Means usually inflammation. So can there be an inflammation going on for 2 months? And if so, if you say that it is hepatomegaly, that we normally think of in this child, inflammation, hepatomegaly, like can be viral hepatitis or liver abscess or some such thing. Hepatomegaly, painful hepatomegaly, upper abdomen.
The fever abscess will have more high grade fever and the child will be very sick in initial periods. The mother will not take about 2 months time to recognize that because fever abscess children are sick and with high grade fever. And for this child, and viral hepatitis also for 2 months is very long history.
And the whole history of viral hepatitis is rather different. So what could be a painful, probably hepatomegaly or not even hepatomegaly, something in the upper abdomen with pain and then also there is fever. So can there be perhaps infection looks little less likely because pain would have dominated the scene. Can there be other cause of pain and fever over a period of 2 months, increase in the size of organ, and also with constitutional symptoms? One is infection. Can there be inflammation without infection? Or can be just a vascular congestion? You said that there was no periorbital edema, so probably there is no associated hypoalbuminemia or collection of fluid. Can it be anything else? Can it be congestive hepatomegaly? Congestive hepatomegaly would have given rise to.
And breathlessness.
Suppose it is a tertiary syndrome that is post-sinusoidal, then
Child may have periods.
no, they may not be. Plus, significant hepatomegaly, pain probably yes, and fever may or may not be there. Will there be a pedal edema or periorbital? Probably periorbital edema perhaps less likely. Middle edema is a possibility. So do you think it's a congested hepatomegaly as a result of something like a tertiary syndrome?
Can be one of possibilities.
Okay. The points in favor of 2 months is not a very long time. Distended abdomen, or more or less the uniform distension with some pain, but with fever also. 2 months of fever probably not in favor of congestive hepatomegaly. Can it be malignancy? Hepatomegaly, and the child has 2 months of fever with constitutional symptoms. If so, what kind do you think?
Could be malignancy, sir, because only organomegaly in upper abdomen and with other symptoms like decreased activity and decreased appetite, and it can be hepatoblastoma, which is most common. But age of presentation is up to 2 years they present most commonly. But hepatoblastoma can be one of the most probably possibility, or HCC we can rule out, but HCC has will be more having more cirrhotic features.
So we have considered congested hepatomegaly because it has occurred over a period and relatively short with pain. Fever shouldn't have been there. But fever, organomegaly over a period of 2 months and constitutional symptoms, if not infection, malignancy and inflammation are always on the cards. There is no suggestion so far of there being a fluid there that, but there can always be some hypoalbuminemia which is not clinically or clinically visible. Any other possibility which may be, can it be some other lymph nodes, etc., which are there? Usually not in the upper abdomen over a period of time. They will not present as progressive distension of the abdomen. So progressive is distension, upper abdomen, probably hepatomegaly, going on for 2 months, not a very long period of 2 months. It's not going for 6 months. Pain and also fever. Normally, the malignancy will not be very painful, but if it has occurred for a relatively short time, there may be some degree of, if not pain, some discomfort. Any other, can it be a hematological problem? So we have considered primary malignancy of the liver, or we have also considered that it could be something like tertiary congestive splenomegaly and hepatomegaly. Can it be something? Can it be a hematological problem? Allows splenomegaly will be more prominent in this kind of. There can be hepatomegaly, but in hematological problem, you would have seen pallor as one of the important manifestations. But please remember, the parent may not have noticed pallor. There are no other things like purpura, so hematological probably no there. Anything else? Any immunological resistance like this? Fever for 2 months. Oh, sorry. If fever is for 2, abdominal distension for 2 months. We really don't know any immunological manifestations occurring as progressive hepatomegaly, though fever can be on and off. So immunological probably no. So we boil down to congestive hepatomegaly, if it is a hepatomegaly, or as a result of new growth, including tumor. Acute infection looks less likely, congestive splenomegaly or congestive hepatomegaly to be kept in mind.
I think we are sure that it's a hepatomegaly. It's coming up gradually. Now, could it be that this liver, which is apparently coming up, is a push down liver? It's not a liver disease at all. Something in the chest is pushing down the liver slowly. And now you say upper abdominal distension. Okay, hepatomegaly, yes. It's not a hepatomegaly in that sense. On examination, the scan may be normal. But for us, yes, upper abdominal distension. Could it be something in the chest? No, no.
Respiratory symptoms will be there. Something, that's right.
For example, something occupying in the chest, which is not painful. Okay, in the lower lobe of the lung. And there is a mass there. It may not be painful. It's pushing the diaphragm down. It's making the liver enlarge. And we are talking about hepatomegaly. No, not that. I understand it's a hepatomegaly. I'm just putting up different thoughts in your mind. Okay, an examination will show you the liver is enlarged. At which time you will tell me, no, but scan is normal. So it's the liver is pushed down. That is different. So can you clinically bet that there is nothing in the lung? And therefore the answer is, there is an abdominal pain in this. Could it be a pleural pain? A pleural pain is seen as like hypochondrial pain. The pain also may be pleural. If the virus is in the lung and you have a pain and swelling, what's your comment on that?
Pain will be more while breathing.
Fine, and therefore we need to give all those treatments. What is this kind of a pain likely to be? A dull ache. Dull ache for a long time, okay. And that's why it is 100% not a push down liver, but just a thought. Can you find some level there, keep in mind that it's pushed or not, but you're rightly said that that's an acute pain. That's a pain on increasing breathing, yes. So now we are sure that it's a pain in the liver. You already said several times that pain is inflammatory commonly, this is not. Why is it not? Pain is there, swelling is there, two parts of inflammation are there. Okay, warmth, maybe fever, so warmth is also there. So why not inflammation?
Time to be more sick located, more sick child is inflammation.
The inflammation will be in the liver and hepatocyte, general inflammation. Okay, and that would have presented it on us. So this is not a hepatocyte disease or a biliary tract disease. So that is one. So this is unlikely to be an inflammatory disorder. And further, it's gradually increasing. All those are not gradually increasing, they are static things. So if somebody has a hepatitis, whatever hepatitis is, the pain is constant. The pain is not increasing in intensity. So this means this must be a tumor only. Whatever increases in size over time is a tumor. So why not hepatoblastoma? Give me the reason why it is not hepatoblastoma. Gradually increasing and slowly painful. So the reason is hepatoblastoma or any tumor or any mass in the liver is not going to be in entire liver but localized. Therefore, what is the cause of this dull ache in the liver? This capsule stage. What do you mean by capsule stage? It's a general hepatomegaly. And therefore it's not local. Therefore it's not a tumor cyst or whatever. That's how we come to a conclusion that it has to be a vascular. Okay. Now vascular, arterial or venous? When you talk of infarct, you talk of arterial and venous infarct. So vascular is right. Arterial or venous. And you have two systems there. Okay. So systemic and portal venous. So who would tell me whether it is arterial or a venous? Simple answer. Okay, I'm just putting the thought into your mind to, yes, you have something? Arterial problems produce infarction, venous obstruction causes swelling. Suppose you have a sudden stroke. How do you know it's an arterial or venous? Arterial is without anything focused, infarction. Venous obstruction causes because the drainage is obstructed, so there is an encephalopathy. The brain is swollen.
And also in the region of arterial supply.
And therefore, this is a generalized venous obstruction or congestion. To get the diagnosis straight,
Why should there be fever?
now that's the question. Okay, so far so good. We have discussed very systematically. It has to be a venous and generalized venous. That's why hepatic vein. Hepatic veins or a portal vein, two systems, so both are venous. What do you think? Hepatic venous obstruction or a portal venous obstruction?
Then it depends, there's support.
There's no way.
There's no way.
So the point is that would it be a pre-sinusoidal portal hypertension? No, it would not have the only a spleen. Could it be the sinusoidal obstruction? Let's say hepatocyte, we would have had edema, etc. So could it be now extrahepatic but post-sinusoidal? And that is what exactly we are talking about. Okay. But level. And therefore, there is a post-sinusoidal obstruction. Whatever the cause. And that's how we come to a conclusion, right? Now, explain the fever. But look at that fever description, undocumented. But that's okay, it could be still high. No diurnal variation, not associated, and response on symptomatic medication. What does that mean? It's unlikely to be a progressive cause of fever. And that's why it is getting better. For example, an autoimmune. Look at the systemic onset GI, fever, but next 12 hours, no fever at all. So, this is not that kind of fever coming up only 2 or 3 times. It is not continuous, but possibly not upsetting the child. And whenever there is a fever of this kind, it could only mean that there is some damage occurring to the cells in the body. What is the cause of fever? A cell damage that ends up with cytokine burns, and that causes fever. So but not high fever. High fever is always severe inflammation. But a cell damage could be of any kind and mild fever. And therefore the fever has come up much later. We would like to know the fever, the way it has gone on. But apparently the fever seems to be easily relieved. And the child is not getting sicker. Therefore, it is obviously some cell damage which is occurring, nothing beyond that. And we may not rush into that, or it could be totally an unrelated issue of you. It has come up with. And therefore, the diagnosis is a post-sinusitis obstruction. Okay, but it's not a causal action. Therefore, hepatic failure.
Can it be a storage disease? Can produce some vague symptoms. There may be fever associated, low grade fever, depending upon what is being stored. Hepatomegaly. Therefore, progressive abdominal distension will be a storage. Whatever.
Pain and
was
fever.
Do you think that the duration is okay with the storage disease? If you told me progressive distension of the abdomen for 6 months, progressive distension for a long 2 months was a relatively short time. For so much apparent distension to occur that the child was brought for abdominal distension. So storage disease, though, is one of the commonest cause of progressive abdominal distension, hepatomegaly. This child, it looks little lower down and therefore we come down to 2 months is not a very long period. So probably yes.
I think only one time that I recall a child who presented with what looked like a bacha. But the story was a little different. The mother had noticed some fullness on the right side, hypochondrium, but the child was fine. So she thought that possibly she could wait. And after about few weeks of this observation, one day suddenly the child developed ascites. Now that was a hepatoblastoma causing hepatovenous obstruction. Okay, what have we learned by that? First one could be acute or chronic. Okay, acute onset is sudden, okay, sick child, chronic, presenting slowly.
It's always isolated hepatomegaly. We always put vascular field to mind whether it's there or not. So
Yes.
this is what we boil down to at the moment. Does it explain everything? It explains some discomfort, some fever, some pain, all these things. In a sick child, is becoming symptomatic now and onwards. Findings. Physical exam, your throat physical? No.
Just one more point, hepatoblastoma child looks almost not sick. It's a localized malignancy, and child looks fine, even feeding well, gaining weight well more so because of also tumor there. But like what we think about malignancy is a fastly worsening situation is no longer true. You must have seen Hodgkin's lymphoma, for example, going on for a long time. Okay, not a sick person. So sickness is also a very variable finding in malignancy, depending on how fast and how spread the lesion is. Epidoblastoma is a localized, but look at the neuroblastoma. High fever, sick child, and the tumor is even not seen. Because it's a small tumor in the adrenal somewhere. And often we diagnose it when the bones get secondary. Till then, that is not even visible clinically, nor suspected even by image. It's such a small tumor. So we have a lot of variation, like, right? So can we examine first and then give the finding?
Just a small point with hepatoma, poroblastoma, and have jaundice. See, viral hepatitis, mild illness, jaundice. Hepatoblastoma, big illness, no jaundice. Localized, therefore, there is limited number of hepatic cells are affected, other parts.
We can put this out.
Yeah.
Suppose we are little long in interpretation, and this particular child's upper abdominal distension is not due to organ anomalism, but due to fluid collection. And what could be the cause of it?
Then you have bed. So it's just observation, okay? Just observe, because you will start crying, okay? Yeah, doesn't matter, just first look at that way, then you will put it, okay, fine. This one is a no, it's not talking, doesn't matter. As usual, growth, development, okay.
3-year-old child, length. Also look at the mother.
We may have to stand beside all they can see the child, yeah.
It's moderately built child. Then on examination.
First tell me how is the growth of this child? Just guess what should be the weight and the length of this child. Say whether it is near normal or very abnormal,
Near normal.
near normal. Okay.
Length is
Looks
not
thin,
bad.
Looks thin, but even the mother is thin. Okay. And therefore, what does it tell us? The illness has not been going on for a long time. Okay, that's why. So by looking at, will not disturb the child first now. Okay, now what else do you find out? Obviously, there is no edema anywhere. Okay. Then
Pallor.
fine. All right. Now we will have to see the abdomen, but let's see the baby. थोड़ा पेट दिखाना है ऐसे ही करो।
आपकी गोद में ही रखो,
गोद में रखो।
हमारे तरफ पेट करो, बैठने दो उसको,
हाँ बैठा ऐसे
वो हाथ आगे आने दीजिए।
We'll make it a quick thing.
Those distended mainly in the upper abdomen. There are few dilated wounds. Flanks are not full.
You want to comment something more in the upper abdomen?
What is that happening means?
There is one prominent swelling around of left upper abdomen.
Not a uniform swelling like there seems to be a bulge on the left side. Something in the region of left lobe. Or we will keep in mind whether it is coming from below the liver and we think that it is liver. That also is coming from here, the liver may be here, this is coming from somewhere else. We take that also. On the right side, is there any bulge? No. It's not such a uniform enlargement of the abdomen. Look at here, look at here. So there are, so to say, bulges in the so it's not a uniform. So vascular problem is less.
Yeah.
Okay, so we now come down to localized.
You can almost see two bumps there. This is very unusual. Right? Where is the umbilicus? Good job. Okay. Flanks.
Plants are not full.
Okay. So you get a lot of, but see, you can see something different there is what it is. Okay. The question is, now on palpation, we will have to see what that is. But you can see that way. You get it? Could it be just the hypotonic muscles which are, right? For example, earlier when polio was common, we would see a small area, okay, which is paralyzed, abdominal wall. And then whenever he cried, it bulges. Okay, and I'm sure on a surgical side, undergraduate, you must have heard that you will have to say whether it's extra abdominal or intra-abdominal. So we are not sure whether it is extra abdominal or intra-abdominal. Okay, on palpation we can make out, right?
When the child cries, the abdominal muscles are tight. If it is into the abdominal wall, it will become prominent. If it is inside the abdominal wall, it will not be.
So now, can somebody palpate quickly and give us?
अच्छी भाषा बोलते हैं.
काय नाही करायचं, हा? काय नाही करायचं.
तुला चॉकलेट पाहिजे? चॉकलेट पाहिजे तुला? हा? पाहिजे तुला खेळायला पाहिजे? चॉकलेट पाहिजे? 15 दिवसात एकदम जास्त असेल. ड्युटी वगैरे काय होते? सगळं 2 महिन्यात वाढलं. त्याच्या वगैरे एकदम चांगला.
Firm liver, irregular margins.
Let's go right now.
Separate, they are separate, can be palpated separately.
Mass over here. There's a mass here given is quite formed to have. It's a mass here, the from here. There's a notch between the left and right. And I come over. So right lobe, there's a mass placed lower down. The left lobe, almost the middle of the lobe. And the entire liver is formed. And mainly when we see the surface is slightly lobulated. So it's not only these two masses are there. There are likely to be multiple small, long, so to say, masses that are there. These are too visible. There may be more inside. Not very tender. Otherwise, it was abscess, you have jumped. Sorry. I've not seen the upper margin of the liver, but that also needs to be done.
Spleen is small.
दुखत नाही नाही दुखत नाही दुखत
रडतो का? रडतो दुखतो म्हणून हात लावला ते दुखतो.
असं तू बोलतो दुखतो but tenderness not much. There is spleen, doctor. Is there a spleen again?
Thank you. This is all the finding.
It's relatively wasted, though his growth is okay, nutrition wise.
General examination. Pulse rate of 110 per minute, RR of 26 per minute, saturation maintained, peripheral pulses and central pulses well fed, extremities warm, pallor present, no icterus, cyanosis, clubbing or lymphadenopathy. Head to toe, moderately built, pallor present, abdominal distended, rest are normal. Anthro-wise, child weight is 11.4 kgs with height of 91 centimeters, which comes around -2 to -1 standard deviation. Weight for height is -3 to -2 standard deviation, which comes to ma'am. Then on per abdominal examination, inspection distended in upper abdominal, few visible veins, flanks are not full. Palpation, no guarding rigidity, liver 9 centimeter palpable below right costal margin, non-tender, hard, nodular, irregular margins, sharp border, left lobe palpable 5 centimeter below Ziffy sternum, spleen 1 centimeter below left costal margin, a liver span of 15 centimeters, dull node present, no free fluid. On auscultation, vowel sounds present. Rest of the systemic examination are within normal level. So, my case, 3 years old male child with massive hepatomegaly with splenomegaly with anemia without ascites or any other bleeding manifestations or other signs of liver failure in a birth and developmentally normal child is probably a case of any hepatic malignancy, storage, or Indian childhood cirrhosis.
Is there any compulsion to give three diagnosis? Because the others would don't look the possible. You may give differential of what that hepatoma, but storage with such a non-uniform growth, bulges here and there. And Indian childhood cirrhosis, of course, you are not saying, but yeah, I mean, it's a relatively longer story. Form, liver, spleen also, portal hypertension. So from, there's no doubt that this is some growth there. The question is whether it's primary or secondary. And also 1191 centimeters, okay, 11 kilos for 3 years is quite less. In which also feel.
I think what you are describing is not a mass. You are saying the right lobe is enlarged, left lobe is enlarged. That means the entire liver is enlarged. But what we saw on inspections looked like there were two masses of this. So the question is, are we looking at a generalized hepatomegaly which is formed and maybe nodular, but that big nodule like this is unlikely. So what we saw on inspection looked like two masses there. But your findings are really, it's not a mass, it's a diffuse thing. So I think that we will have to confirm really very well. And that's where you are putting up hepatoblastoma there. I'm not sure whether hepatoblastoma could be on two distinct tumors in the liver. I'm not aware. What I've seen few cases are only one single tumor. So that doesn't look like that. Now, could it be something which is not malignant or semi-malignant, but it has come up in a short period? So there is something missing here to my mind, and the story looked like a slowly occurring hepatic venous obstruction, but an inspection looks something very different. So we'll have to now confirm with the imaging to see what it is really. And I'm not sure whether it's two masses there. Your description is not a mass. Your description is an entire liver. But an inspection looked like that. So again, back whether it was really a hypotonic muscle, whether it was still bulging, we don't know that, right? Yeah. Let's see what the investigation tells.
Hemoglobin of 8.3 with hematocrit of 26, counts were of 10,000, platelet counts of 3 lakh, 3.45. LFTs are within normal range with some transaminitis. INR initially was 11 and 1. The child was admitted to our side on around 1st of October. So at that time our INR was 1.4. He was being evaluated outside for autoimmune hepatitis where ANA, SMA and LKM1 was done, but which was negative. ANA was weakly positive, HbSAg is negative. Total protein and albumin is within normal limit 6.6 and 3.6. GDT is slightly elevated for 39 and LDH is 317. Ceruloplasmin has been done to rule out Wilson's, so 36.9. These investigations were done from outside hospital. At our site, outside USG were suggestive of appearance of liver cirrhosis and multinodular appearance. we repeated a ultrasonogram from our side. So they have established that IVC appears normal, and most probably they have given features suggestive of Budd-Chiari syndrome in view of compressed IVC. But hepatic vein flows were within normal limit. The child has been planned for liver biopsy after CCT. It has been not done yet.
CT is not done.
No.
I think nodularity is unmistakable in this particular. With congested hepatomegaly, I will see a very uniformly enlarged. This side very visible, not only palpable but visible. No, I can feel too. There may be some other modularity which I am not aware. And the liver, the three-dimensional structure, so whether they so. I think mass in the liver is the diagnosis. Infective mass unlikely. And the view of it has to be malignancy here, I thought. Either primary or secondary, we do not know, but for secondary, no, nowhere else there is anything from nowhere it is coming. So maybe primary, but multiple. Your USG is suggestive of IVC obstruction, is it?
They have said कि IVC normal appears narrowed due to some external obstruction. So it could be that liver mass only which could be compressing IVC.
Yes, definitely.
I think the only difference I happen to mention what I've seen as a hepatoblastoma. But the story is not like that. Again, see, whenever there is a discrepancy, we must go back to the parents and ask them more details. How long is he suffering, etc. Because if these two masses have come up in a 2 months time, then it is very difficult to consider whether they are malignant or benign, what kind of things are there. But one is certain that the story is of a vascular obstruction. Okay, we thought it was simply a Budd-Chiari, but on inspection only we saw two masses, which looks like, and it's not a nodular cirrhosis. No, cirrhosis is a chronic liver disease with albuminuria, edema, etc. And I think that's why what you will have to learn as well is it's fine to rule out everything, but it becomes irrational. Why should you do viral studies, autoimmune studies, Wilson studies? No, it's not a hepatocyte disease. So just because it is liver, you can't say every known cause of liver should be ruled out. No, that's not fair. I mean, here the patient doesn't pay, but still, we are irrational in that. Okay, so to that extent, I feel the biopsy is a must. Maybe that's what you're planning. And again, the request that you must tell us what it is.
Yes.
Okay.
CT they are going, you are doing a CT.
On this Saturday, he was planned for biopsy on this Wednesday, appointed also, but radio seniors thought it could be a vascular, so they would not take a blind.
Fair enough, fair enough. Good, so I think what we learned from this case is that history did suggest a vascular chronic venous congestion or the cardiac failure. So obviously a Budd-Chiari-like syndrome, but on inspection, we could see some two masses, and clinically it's not easy to define what those masses are, but it's certainly not a nodular cirrhosis. That's not seen in pediatric practice clearly, and not such big nodules. So ultimately, imaging, yes, and then maybe even a biopsy under vision, not blindly, would be an answer. But you must let us know what it turns out to be, because it's something unusual, right?
CT should give us fair idea as to the masses, they are independent, dependent of whether they are displaced. But I think we have more to the diagnosis than a tumor or a mass, primary, secondary, we don't know that. Nothing else fits in study.
Anjali, any comments from anybody there?
Sir, I thought
comments?
cirrhosis is. Sir, can you hear?
He wrote something, but I don't read it properly. Want this, doctor?
Hello. Cirrhosis is micronodule. Good evening, sir. I'll be presenting my case. Uh, 10-year-old boy, second by birth order, born out of non-consanguineous marriage, resident of Dharavi, hailing from Maharashtra, Hindu by religion, brought by parents with complaint of fever for 3 days, 1 week back, swelling over bilateral neck for 3 days, 1 week back, cold for 2 days, 1 week back, vomiting since 4 days, and puffiness around eyes and face since 3 days.
Case was seen. First case was seen there in that.
Please give the first slide, just a presenting complaint.
10-year-old boy, second by birth order, born out of non-consanguineous marriage, resident of Dharavi, hailing from Maharashtra, Hindu by religion, brought by parents with complaint of fever for 3 days, 1 week back, swelling over bilateral neck for 3 days, 1 week back, cold for 2 days, 1 week back, vomiting since 4 days, and puffiness around eyes and face since 3 days. Child was apparently alright 1 week back when he developed fever, undocumented, initially low grade, progressed to high grade, intermittent, associated with chills, not associated with rash or rigor, subsided on taking medication, active in interfebrile period, associated with cold in form of runny nose. Hello. Hello. Bilateral neck swelling below ear 1 week back, insidious in onset, gradually progressive in nature, painful to touch, not associated with redness or ulceration over the swelling, subsided after some medication given for 5 days. Vomiting since 4 days, 10 to 12 episodes per day, containing food particles, non-bilious, non-projectile, not associated with blood in vomitus, associated with giddiness and generalized weakness. Puffiness around eyes since 3 days, insidious in onset, gradually progressive from periorbital region to face, more during morning and then decreasing as the day progresses. History of decreased urine output since 2 days. Taken to private practitioners, some investigation were done and referred to Sion Hospital. No history of abdomen, abdominal distension or pedal edema. No history of gross hematuria. No history of rash or joint pain. No history of similar complaints in past. No history of similar complaints in family. No history of COX or COX contact. No history of breathlessness on exertion. No history of headache, altered sensorium, burning, blurring of vision or seizure. No history of lethargy. Past history of surgery for phimosis at 1.5 years of age. ANC history and birth history not significant. Immunization till 5 years of age. Developmentally appropriate for age. Studies in 4th standard.
First. Yeah. Get the next slide. Yeah.
What was the presenting complete first slide?
Fever for 3 days.
8 days back.
Yeah, 1 week back.
So there was, if you go 11 days back, he started with fever, which was there only for 3 days. And thereafter, there has been no fever for last 1 week or so. Was it treated?
Yes, sir.
Okay. The fever was very high.
Initially low grade and progress to high.
But that settled down in 5 days.
Yeah, but with treatment.
Yes.
And the bilateral lymph nodes.
Then the lymph nodes.
Yes.
Did they appear more or less simultaneously with fever? Because you said they were also there and they are not there now.
Simultaneously with fever.
So fever and the lymph nodes both sides, bilaterally, neck, just below
Yes.
the neck, you said.
Yes, sir.
And last, after 3 days, the fever subsided.
Yes,
Are
sir.
the lymph nodes also subsiding?
Yes, sir.
The apparent
After-
swelling has subsided. Don't know whether it was infrared. So something started as fever 8 days back or 10 days back, 11 days back, and came along with swelling of neck both sides, increasing in intensity. And with some treatment, the fever also subsided and the neck swelling, we don't know subsided or no, but at least decreased in size. Okay, history wise, what that swelling painful to touch? Or-
Yes, sir.
So it was
Painful.
tender swelling both sides in the neck along with fever. And with treatment, both have either subsided or decreased in size significantly. Okay, we will go further, but here, up to here, what is your analysis?
Um, Acute
Was there
infection.
any dysphagia, any pain on swollen?
No, sir. Acute infection 1 week back. Then after 1 week, he developed.
So inflammatory swelling bilaterally in the neck, most probably infective inflammation. There probably is a correlation between starting of treatment and the treatment was given for 4 or 5 days. So starting and treatment and then fever and the swelling was subsided. We don't know the swelling has completely disappeared. And something which has started relatively abruptly with the fever. Fever and the started relatively abruptly. Means Sunday there was no fever and Monday there was, but the fever was not high at the onset.
At the onset, the fever was at low grade and then progressively became high
It
grade.
came up so suddenly, I thought the fever should have been high to start with, would have remained high for all those 3 days, and with treatment, it should have subsided. But even then, let us say that bilateral neck swelling with fever for 3 days, subsiding with treatment, most probably, should have been an inflammatory swelling, most probably infective inflammation, and most probably a bacterial infective inflammation. Whether it was primary, because both sides is little unusual. So is it secondary to something which was like throat infection, bilateral tonsillitis, something? We don't know that. But it occurred simultaneous both the cases. So I thought that something must be there inside the throat, and these were there as a result of the primary throat infection, rather than primary infection, both sides coming up suddenly is less likely. So it occurs suddenly. So up to here, this should be the analysis. Now what happened?
Now the patient developed vomiting and periorbital puffiness and facial puffiness.
Periorbital, both the eyes.
Yes, sir.
Upper and lower eyelids is what periorbital means, both the eyes all around.
Yes, sir.
And then,
And then the periorbital edema progressed to face.
so what has happened now? What is the pathology of periorbital edema simultaneously occurring with edema feet? Hypoalbuminemia? No, right. 2 days, 3 days, no hypoalbuminemia. Vascular? No, they're far place. What is that? What is that? So it has to be accumulation of fluid only. It is accumulation of fluid only around the eye orbits and below. That means it is as a result of retention of fluid. It has occurred as a retention of fluid, more or less likely perineal more like. So maybe he has some degree of renal, right? Due to which there is fluid retention, which has occurred relatively acutely after a respiratory illness. Okay, so maybe as a result of or as an immunological reaction to a respiratory illness, maybe it was streptococcal also. If I have to connect all the three, the periorbital edema and puffiness and the edema field looks as a result of vascular only, not as a result of hypoalbuminemia. And vascular means not an obstruction. So retention of fluid is a result of involvement of kidney. Whether it is hypertensive or no, we do not know that. And if there was a prior history of an acute bacterial infection, I could only think of this as a possibility. So not hypoalbuminemia, but retention of fluid, secondary to inflammation, probably renal.
I think we are sure that this is an acute onset viral infection till proven otherwise. It's not bacterial. It would not have come up with bilateral swellings, and therefore it's likely an acute viral or an immunological problem. Multiple lymph nodes suddenly coming up. But that immunological problem would not have disappeared within a short period, and therefore probably this is a self-limiting viral infection as the first probability. We keep in mind an immunological disorder because what is common to immunological disorders in general, a sudden appearance, sudden disappearance, and often recurrence. So we have got first two there, sudden appearance and quickly disappearing. So we keep that in mind. Okay, now we go further and vomiting. Now, it's important for us to know that how long did the vomiting last? Only for a day? Or he's continuously vomiting?
4 days he was continuous.
So 10 to 12 times every day for 4 days? Now, all these details are very, very important. Okay, because it doesn't fit in what's happening thereafter. To my mind, if vomiting has remained for 3-4 days, and also the urine output is reduced, but also edema is there. So these things are not correlating very well to that extent. We'll ask them more details. Okay, but this is important. I think we have always said that history taking is a thought in action, not like a robot. Each time when the first question is asked and the answer is given, you start thinking what it could be, and your next question should be related to that. Unless you do that, history is not complete. So I'm not sure whether the vomiting 10 to 12 times, acute onset and remaining for 4 days looks little unlikely to my mind. Of course, it could be there. I'm not doubting your history, but we will check that. And what happened thereafter looks like that there is some renal problem coming up. And let's call it a nephritis till proved otherwise. So a viral infection ending up with some nephritis, where in between that vomiting for a long time is not easily explainable, but vomiting for a day could be, because any acute insult. Now it's an immunological insult when it happens to the renal system. So that could cause vomiting for a while and then vomiting disappears. But if lasting for 4 days, it's too long a story. And therefore, the point is acute glomerular nephritis typically could be streptococcal, post-streptococcal, but it could be also with many other infections. And the difference is a post-streptococcal acute glomerular nephritis has an excellent prognosis. 99% get well in the first attack itself. Whereas when other infections cause glomerular nephritis, it is often a prognosis which is not very easy. What's happening there? काय होत आहे काय होतं काय होत आहे काय म्हणतो he seems to be not fine. Right होता ना तुम्हाला त्यांना उलटा होतो त्याला बरं किती दिवस उलटा झालं रोज उलटा व्हायचा आणि 10-12 वेळा व्हायचा उलटी व्हायची तर तोंडात थोंबत राहायला ना का उलटीच करायचं पण 10-12 वेळा नाही तुम्ही म्हणता जेवणावर उलटी व्हायची ना इथूनच व्हायची ना जेवणावर आणि पाच वेळेस थोंबची करायचा हा काय होतं नाव सांगा ना माझ्याशी दोन एकांतर तुम्ही घेऊन जाताना आपले सर्व बोलतो मी तो आमच्या What the father told me, he said he is vomiting so often. Then the mother said, vomiting after feeding, after eating. So then I asked the mother, after eating means how can it be 10-12 times? To which she said, it's not 10 times, he's spitting out 10-12 times, but he vomits after eating. Now, I don't know how, well is he eating either? He could be, so possibly, he is certainly looking sicker now, and we don't want to kind of hold him up here. Okay. See, the point I want to make out is, if somebody is vomiting acutely 10-12 times, okay, till proved otherwise, it's surgical. Okay, medical conditions also protocol, but intestinal obstruction, for example, severe acute onset vomiting. Medical vomiting is not often so acute and no frequent. In general, of course, exceptions occur, but whenever there is a sudden vomiting and profuse frequent, it's an obstruction till throat alone. But then there would be abdominal distension, pain, etc. What mother said was he keeps on spitting. So something that makes him nauseating maybe, that must be the reason, right? And now he says he's getting some discomfort here. We don't know what that discomfort is. So I think take a note, if they are sick, then don't bring them here also.
Yes.
We should not have any problems coming up on that. Now
Yes, sir.
let's look at what you are saying. So looks like nephritis. Now, if it's an acute immunological problem coming up, for a while vomiting could be discussed, considered in varieties of it. But it's not 10-12 times really. And to that extent, he is uncomfortable. We don't know whether he has an acute onset inflammatory immune mediated disorder coming up with renal problem. Again, when he has a decreased urine output, we want to know how decreased. Is it
The-
close to anuria? If that is so, then you have an acute renal failure coming, which is even much dangerous. And you look little sicker for all that. And that's why, again, the details of what is molecular would mean, right?
The frequency was decreased, but the mother. The frequency of urination decreased, but the mother did not notice a very much decreased urine output. But the frequency was decreased. Anthropometry, weight 52 kg, corresponds to plus 2 to plus 3 standard deviation. Height 151 centimeter, corresponds to plus 2 to plus 3 standard deviation. BMI 22.8, corresponds to plus 2 to plus 3 standard deviation. Interpretation, overweight. Dietary history, there is no calorie or protein deficit. There is no significant family history. Summary: 10-year-old boy with complaints of periorbital and facial puffiness, vomiting with history of fever, cold, and bilateral neck swelling 1 week back, associated with decreased urine output in a birth and developmentally normal child. Overweight by anthropometry is probably a case of post-infectious glomerulonephritis or nephrotic syndrome. On general examination, a febrile, heart rate 100 per minute, RR 26 per minute, saturation 99%, BP 150 by 100 mmHg, which corresponds to 99 greater than 99 centile. Peripheral pulses well felt, central pulses well felt, extremities warm, pallor present, periorbital puffiness present, pedal edema, pitting type up to ankle present, no icterus, clubbing, cyanosis, lymphadenopathy. Head to toe examination,
Nothing much, then you can skip.
on systemic examination, per abdo, soft, non-tender, no organomegaly, and rest of the system also no abnormality detected. Diagnosis: 10-year-old boy with complaints of periorbital and facial puffiness, vomiting, with history of fever, cold, bilateral neck swelling 1 week back, associated with decreased urine output in a birth and developmentally normal child, overweight by anthropometry, is a case of post-infectious glomerulonephritis. CBC. Initially on admission, HB was 8.6, which dropped to 7.4. And the indices shows microcytic hypochromic picture of anemia. LFTs were normal. Total protein albumin was 5.2 and 2.7 albumin, which was normal. The trend of RFT on admission, BUN was 68 and creat was 3.5, which was increased to 95 95 BUN and creat 4.8. After that, the patient was taken for dialysis, and the BUN creat started decreasing. And on serum electrolytes, sodium shows there is hyponatremia and hypokalemia was there. On urine RM examination, urine protein present, blood present, RBCs was there. Initially field full of RBCs, and then after the dialysis, the RBC decreased. Pulses was there, cast, granular cast present, and bacteria present. USG A plus B shows bilateral bulky kidney with slightly raised echogenicity with maintained corticomedullary differentiation, mild free fluid in pelvis present. C3 complement C level complement 3 level was low, C4 was normal, ASO titer is high. UPCR 6.25, जो one antibody was positive, urine culture negative. We did biopsy. The biopsy shows immunoglobulin G and C3 is positive on immunofluorescence. And the diagnosis was infection-related acute diffuse endocapillary exudative glomerulonephritis with crescents. Thank you.
I think we are clear that this was a viral infection. And when we said that viral infection leads to glomerulonephritis, it's something different than a classical post-streptococcal AGN with good prognosis. So that is number one. Second is, we need to look at what that vomiting really would mean like. As I said that, to me, it means that there is an acute onset of an autonomic nervous system stimulation. Why does that happen? Anything acute change in the body, the first response is vomiting. And then what mother said, it feels like nausea, maybe spitting out, which suggests that post-viral infection, this child is developing an acute immunological insult. And that acute immunological result is in the form of nephritis. Now, when you talk about nephritis and nephrotic syndrome, remember nephrotic syndrome is also nephritis, but in which the epithelium is more involved, but endothelium is also involved. In other words, it's a typical nephrotic syndrome. Earlier we used to call it nephritic onset of nephrotic syndrome. So, but this child is almost getting into an acute renal failure. Creatinine has gone up high, okay, and he looks very sick. So this looks like a very progressive, fastly progressive glomerulonephritis, which is a combination of. So what we have learned in this child, one is we need to be very sure what the parents mean by saying vomiting 10 to 12 times. In fact, in our YouTube channel, I did recently, maybe 10, 15 days back, I don't recall. I talked for 10 minutes how to make sure that the history given by parents is reliable. So every time we say that history given by mother reliable. If I ask you, how are you sure it's reliable? You say, you rely on what I say. So I put up my views on how to check, double check reliability. And I think this is one example. But obviously to me it looked like, what have we learned out of this? An acute onset, unexpected vomiting. Okay, we did not expect vomiting in the child who was recovering from fever and lymph nodes. So unexpected vomiting of an acute onset is usually an acute immunological insult or any insult. For example, somebody runs a big marathon, it's an acute insult at the end of that marathon. You may feel like vomiting, you may suddenly get even a neurological symptom. So to that extent, that episode of sudden unexpected vomiting meant an acute immunological complication in the form of liver, kidney, nephritis, but possibly not a simple nephritis to ignore at this point. Now the question is, you must, every nephritis of an acute onset like this, you must make sure how much is the albumin is being lost. He's not massively edematous, but still he has a significant albuminemia has not yet come up, but this may come up over time. He's also hypertensive. Therefore, possibly this child is a bit serious. When he was looking sick, he complained of some discomfort there. That was a worrying feature. And I think we need to look at carefully on this. See, every child, and this looked like a straightforward nephritis, but for that moment. Again, it looked, why was that funny kind of fever? And therefore, typical Epstein-Barr virus may present with multiple lymph nodes, etc. We know that German measles presents with lymph nodes and fever. So there could be multiple viruses doing the same. I was also wondering whether there is going to be, you said below the ear. Now below the ear meant to be parotid. And I said, is this a bilateral parotid? But that should not have decided quickly. Okay, but keep all that in mind. I think every case that we discuss here makes us learn something different. And what this child made us realize, one is you ask history details where something doesn't gel well, like vomiting did not gel well. Okay. Then short interval between infection and nephritis. Look at post-structural nephritis, 2-3 weeks. Rheumatic fever, 2-3 weeks later. So, but there are many infections where acute immunological complications come up quickly, often where the infections are going better. Dengue, for example. The dengue is getting better and you get a complication. So, this is one different kind of infection causing nephritis, and that itself means that you need to be careful about his prognosis. He could run into a chronicity, he could run into an acute complications like a renal failure. Maybe that's what we need to be worried about. Obviously, he came in on wheelchair at 10-year-old. The arthritis would not look so sick. Maybe it would not acutely shake like this, right?
Sir, metabolic was not, if somebody vomited 10, 12 times, you should have, for 3, 4 days, you should have been significantly dehydrated. So maybe he was more nauseatic and only a small amount. Mother, we could call it vomiting only. There may be some element of force feeding also and then work. Sir, another apart from maybe metabolic, because the metabolic abnormalities where you
Hyperkalemia.
and even the urea maybe creat was rising and that was also a cause of so-called nausea and vomiting in this particular case. Well, that particular damn thing which looked like streptococcal should not have come short time and should not have disappeared in a short time. Though it looked, we call it streptococcal most of the time, but it was not streptococcal. EB viral infection possible, this is a unilateral, so EB viral, there's a bilateral. If this was here, it was, I thought more of jugular digastric. And jugular digastric is secondary to tonsillitis. So therefore, whether it was a bacteria, but sudden appearance and sudden disappearance of tonsillitis with not so much of an aggressive treatment. Okay, maybe it was self-limiting viral infection. That 800 ASO, etc., probably does not have much meaning. We don't know that. We don't know how much is the ASO of everybody, and therefore whether it is significant or not. Dr. Anjali, are you online or you are not?
Yes, I'm online. I'm online, Dr. Khare.
Probably she was not able to went online. Let's see whether she can. Dr. Anjali, any comments? Probably she could not hear the discussion, or or whatever comments she's making, we are not able. So metabolic, she wants to say.
HUS like presentation. We can hear you, Cece.
HUS. Whatever HS I have seen are secondary to GI infection. Here it was secondary to respiratory infection.
Vomiting could be due to uremia.
I think the HUS, hypertension, yes, renal problem, yes, okay, but there is no hemolytic anemia really, that is the moment.
Yes, sir.
Yeah, so the point is, it starts typically following some method. So that part we know, HUS is also a neurological disorder. But at this point of time, I thought looking at the old story, it starts with an acute renal failure only. Okay, vomiting and sudden manifestation of edema, hypertension. So it's a fastly progressive nephritis. HUS, we'll have to see how it progresses further. Okay, whether you get the other components of the HUS.
Peripherals, we have functional
That's
side.
right, absolutely, absolutely. So you might have to look at that because I recall one HUS which came primarily for hypertensive cardiac failure. Okay, and looked like an acute glomerulonephritis with hypertension and cardiac failure. but slowly evolved into a typical HUS. So again, all these are possibilities.
HUS to be kept in mind. Many times, there is no very obvious evidence of paralysis. We had about 40 cases of HUS following Shigella. And that was way back in the 90s, so because there were so many cases from Hyderabad also at that. But we could not really pick up schistocytosis on peripherals, but we picked that. And there is persistent HUS also. One is the usual and there is what is the other HUS, those are the atypical. So whether it is going to be like that.
And again, non-Shigella HUS is more dangerous. So this could be an HUS, yeah.
And also there is already a crescent formation taking place in some of the glomeruli. So whether they're going for RPGN or what, we don't.
I think probably they were not able to.
No, they are saying कि they could hear the entire case. They are messaging this.
Okay, okay. Well,
Hello.
good. I think today we had a good two cases. Both looked little unusual. But finally, I think we will know about the first case, what turns out to be after an imaging and a biopsy maybe. And even in this case, what happens subsequently on a follow-up would be of importance, but we know that this child, both of them were unusual to small extent. And I think we were right in calling that partially, we are right in calling this as partially progressive glomerulonephritis with acute renal failure. Whether which neurological problem we will have to look at that. Okay. Thank you very much, all of you, for joining this session, and I hope you are able to see here, and we hope to meet now. Now, there is a small issue now today. One is we have been deciding to meet once in a fortnight. And fortnight later is a Diwali time. So the question is, do we meet 3 weeks later?
Today we are meeting, so next Thursday we should not be meeting. And then Thursday after that we should be meeting, but Thursday after that is Bhau. So then you have two alternatives, instead of, because we are not going to meet perhaps on Bhau, as a compensation, we meet next time. Or we don't meet on two Thursdays and straight Thursday. So as a compensation, we meet two consecutive Thursday. Today we have met, next Thursday, and then Bhau, or we don't meet next Thursday as well as Bhau, and then we meet Thursday from now.
We can present next.
We can, we are also very comfortable. We are happy, in fact, to meet next Thursday. So we meet next. Thank you very much for showing your anxiety. So, Dr. Anjali, we will be meeting next week. It's not going to be a holiday. And Thursday thereafter will be a holiday because of our fees. So the students have nicely agreed to compensate by meeting next week and taking a holiday.
Thank you. I think what we also plan now is that for you all also, you could present the case like an examination. What we discussed
धन्यवाद ताई.
हो मॅडम, करते बंद.
हा हा आपण दोघीच आहोत. बंद
हो हो,
करू.
करते बंद.